Hey guys, welcome to this episode of PartyCast. A few weeks back, Evan and I sat down with a friend of mine from high school and college, Dr. Brandon Applegate. He is a physical therapist with a background in strength and conditioning. Not surprisingly, we ended up talking for a few hours, so we decided to break up this conversation into two parts. We really enjoyed having a guest in the studio, and we look forward to being able to do more of that in the future. If you guys have a guest or know of anybody that you think would be good for the show, or that you think is in our wheelhouse or availability, let us know. We'll do what we can to reach out and get them on the show. Without further ado, here is part 2 of our conversation with Dr. Brandon Applegate. Enjoy.
Do you think you could go into a little bit of how to maybe appropriately load someone when they're going through some kind of pain? Specifically, some kind of loaded movement that they could progress on, or something that you're pretty good at coaching at, something like that.
So, like with deadlifts, I do a lot of like mid-range work first. So, they're starting in the standing position. I just kind of, so we have one high load table in the clinic, and that's it. And I get really frustrated about that because, but anyways, I will take them over to the high load table, and then I'll basically raise it to where it's just low enough to where when they start the hip hinge, like the back of their thigh hits the table. So I want them to, the biggest issue with people with low back pain is they can't differentiate movement between the spine and the hips. So when the hips flex, the spine flexes. And that's a recipe for low back pain, because that's when you get your butt wink, especially under load. Like, it's not a good idea. So if you can teach them how to maintain a neutral spine while they start to develop that hip hinge, that's like the like step one. They have to be able to learn.
Can I interrupt real quick? You talked about mid range. I don't think I've ever tried to start coaching someone mid-range. I prefer top-down. Yeah. Can you explain why you do mid-range?
In mid-range, that's when the levers are the longest. So it's going to be the highest demand for stability. Okay. So if they can learn to move with no weight in good form through mid-range, and then you start to load in mid-range, they're going to have an easier time when they're at top or bottom.
I'm almost thinking like training someone specifically with an isometric, like you increase strength and range a little bit below and above. I'm kind of thinking the same thing. That makes sense.
Like ISO holds. Have you done ISO holds in the rack? Yeah. So I don't do those in the clinic because I don't have
the tools.
Yeah. But so we start with that hip hinge, and I just have them hold a PVC pipe in front of them, just so everybody as soon as they start to hip hinge, they stick their arms straight out. Like they feel like they have to hold the bar out in front of them. I'm like, no, just let it relax.
Right. Like gravity.
It's not going to happen when you have weight. Like you're not going to be holding a box out in front of you. It's close to you. But I start with that high table so that they can, develop a hip hinge to start. And then I put high boxes in front of them. And I was using really light dumbbells at the time, but now I have my kettlebells. So, nice. But I'll do a 5-pound kettlebell to start, and they're just the kettlebell will start on the box. So then they stand up, and then just go and back down to the box while maintaining the good form. So as they do that and they build confidence, and they're not having pain as much, we'll lower the box. So they eventually get to where they're just kind of doing an RDL, and then after they are able to do a full RDL, then we do the deadlift. So.
I have a follow-up question. What if, specifically with pain, if you want to, do you just move a little bit below or a little bit above? What if they feel pain in that range?
In mid-range?
Yeah.
I'll regress them basically.
Okay, gotcha.
Yeah. So they're not ready for the next step yet. So, and if I need to add some weight in that mid-range, backwards some, that's what we do. So, and it's okay. It's okay to work through a little bit of pain. Like if they're having which I hate that we put numbers on pain, but if they're having the 3 or 4 out of 10 pain while they're doing it, that's fine. And with tendinopathies and tendinitis type issues, which a tendinitis is a tendinopathy, but if we're having tendinopathy issues, working through pain a little bit is actually beneficial for the recovery. So you actually want to do that. But
I like the awareness factor of the pain, and it's not going to debilitate you.
Yeah.
That was
You
the
know,
thing that we had to like. Obviously, I'm sure you run into it a lot, and we've talked about it too. Like when you've got somebody that has pain, and explaining to them like the difference between like we make it simple, good pain, bad pain, you know, and the idea of like, okay, that pain is like a little bit of discomfort, a little
you mean
muscle
like
burning.
soreness? You killed me yesterday with training. I'm in pain. I'm
Well,
hurting.
like during an exercise,
Yeah.
you know, okay, is that muscles are working and they're muscles that you don't usually use kind of pain, or is that like pinching, stabbing, you know, like
That's
ice pick in my spine pain?
That's one of my like, my like, I get some like laugh out of the day while I'm at work because I'll have somebody doing an exercise and they're like, oh, this hurts. I'm like, does it hurt or are your muscles just burning?
Yeah.
Right.
And they're like, my muscles are burning. I'm like, does it stop when you stop? And they're
Does
like,
the pain
yeah.
stop when you stop?
They're like, yeah, it does. I'm like, okay, that's fine.
Good. Keep suffering, please. Keep going through the pain.
That is,
But
man. Clients say the funniest things.
oh my goodness.
You know, I love that stuff. I don't even know what question to ask whenever I'm like, clearly you're not actually in pain at all whatsoever.
I always have this conversation, and I pick and choose when I have it because it's usually with people who are like scared of like doing something that's going to hurt their back or like hurt whatever is called or whatever is painful at the time. But I always ask them like, what do you think pain like is? Like, what do you think that is happening? Like, you know, and they always have this like association of pain is that there's something that's structurally wrong.
Yeah.
Yeah. And, we know it's not that. It's like a warning sign.
Yeah,
so if you like a dash light or something, you know, if your service engine soon light comes on and you just ignore it, you know, something's going to happen later on. So pain is a good marker that, you know, what you're doing, there's something that needs to be addressed. You know, there's not anything catastrophically wrong. It just, you know, something doesn't feel right. And they typically respond well to that. And they're a little bit more open to movement. Another like, example I give a lot is like if you had a cut on the back of your knuckle and you just kept your finger straight all the time, like the cut would heal, but then anytime you went to move, that thing would re-tear and then it'd be irritable again and you'd be having more pain. Same sense, if you had that cut and you were just bending it
Never
like
heals.
crazy, it would never heal, right? So we want to do that like in between. And that's where like working through that pain a little bit is okay. Like it shouldn't be like you're working through that pain, just, you know, bending it like crazy and
Right. It's like working to the edge of pain. Like
Right,
a lot of times when you're talking about like range of motion, you're like, okay, can I get to the edge of pain and extend it a little bit?
yeah. So I'll always say like, this is your tolerance for movement. Now we touch those boundaries. As we do this over time, your tolerance for movement is going to increase and then it's just not going to hurt anymore.
Right.
So
This might be a little bit tough to answer because it may be a little bit more subjective. But whenever someone creates their own restrictions that you don't necessarily find, I'm sure it's, you know, it could be joint specific or something. But how do you deal with situations like that?
My favorite one is when people say that they can't squat
Yeah.
because of their like back pain.
Yeah.
I'm like, have you used the bathroom today?
We literally talked about that last episode.
Have you sat down on the toilet today? Have you?
Did you get off the couch?
That's the perfect question.
They're like, well, yeah. I'm like, well, you've done a squat. Like,
That's perfect.
you know, you weren't in pain when you were using the bathroom, were you?
Also, I try not to. I don't ever want to be mean, but whenever someone says something about, you know, squats hurt my knees or squats hurt my back, I kind of want to say, well, pretty much all the research tends to disagree that you're going to get stronger and it's going to assist with these things. So it's something else, which is harder to deal with because it could be, you know, a position thing. Or
Yeah. So one of my posts a couple days ago, it was heavy deadlifts and heavy squats don't cause back pain unless you have technique flaws. So that's like what I would bring up to those people.
Yeah.
It's not the motion, it's how you're doing it.
Right.
So
And but if you say that, they don't want to hear it, you know, because then it kind of puts it on you. It's like, oh, you know, like there's something wrong with you specifically, and that's
I have to
what's
take
wrong
personal
with that.
responsibility.
Yeah, it's okay. I mean, nobody's perfect. Maybe change up your stance. You know, where are your feet pointed?
Right.
Have you ever looked down?
Oh man. So we do like assessment or like objective measures or outcome measures. That was the word I was looking for. So like an older person comes in who's just deconditioned, and they have balance issues.
Yeah.
Something like that. I'll take them through what's called a Berg balance assessment for the balance side, and then I'll have them do
I have a question about
a
balance, but keep going.
30-second sit to stand test. So that's a measure of strength for their like lower half.
Mm-hmm.
Every time their feet are right next to each other. I'm
Right.
like, is this how you normally stand up? And they're like, yeah. And then you watch them stand up, and they're like
Right. Grabbing
trying
everything.
to push up from the chair as hard as they can with their arms. I'm like, spread your feet out, and then they just pop up a lot easier. You know, that's I don't know what I lost while we were talking about that or what we said before that. But
We were talking like a little bit about I mean, there's one thing on pain I wanted to notate really quick, but like it's funny how
how people move, that's what it was.
right. and to that extent, like if you're scared to move and you stay locked in this thought of like I can't move, I can't do something. And if you have somebody that's willing to sit there and take the time and explain to you, you can, and I promise you it's going to be okay. And even just something as simple as move your feet out a little bit and like, you know, brace your core a little bit, teach them how to do that. And then like they can pop right up and like, then they don't have pain. Then it starts to kind of erode that fear and that debilitating like thought in their minds. They're like, oh goodness, like this range of motion is bad.
Yeah, like, you know, teaching someone how to do a box squat or stand up from a chair. You know,
Right.
it's like I'm going to watch you and I'm going to stay right here.
Yeah.
And I'm not going to say just stand up and walk away. I'm going to make sure everything is perfect for you. And the people with their feet close together, or if you try to ask them to do lunge or something like that, and everyone's on a tightrope.
Right.
I just wonder, that's how you spend your
It's
whole life.
crazy. Yeah, it's crazy how much like we learn this stuff and we think it's, oh yeah, that makes sense. It's real simple. And then you see people or you work with people and you're like, why are you doing it like that? You know, there's an easier way to do it or a better way to do it. But there's just so much that people don't know.
Yeah.
And it's like what we know is so valuable. And I think like it's hard to like grasp that sometimes. Like
it's hard to express it.
Yeah, that too.
You know, I was going to ask about balance. How much lack of balance do you see that is just a lack of strength?
A good portion.
Yeah.
Yeah. So like
I hear that all the time from people. They say, oh, I need to work on balance. And most of the time I think, well, you're not very strong at all. Mm-hmm. So let's work on that because you have such, you know.
There's hardly ever a time where like I'm working with a patient for balance and we're not doing some kind of strengthening activity.
Yeah.
So
it's going to be some kind of, you know, it's maybe not necessarily like an inner ear thing. It's some kind of coordination issue, some kind of strength issue.
There's a story I like to tell that Evan's heard it before. He was actually there for it, but it made me laugh. So we were doing, like would get bored sometimes in between classes or just as I was coaching sometimes, my mind would wander about other things.
Gosh.
And so like there was one day I had a dead hour. And so like I had set up this little like floor is lava-esque obstacle course of just like foam roller, random, you know, balancing items. And I'm like going around on this little thing and doing it. And my next group had come in and I got done with it or whatever. And I walk over and one of the ladies was like, looked at her friend and was like, man, I really want to hope I'm around when Evan and Jared get old so that, you know, we can see them, you know, lose their balance, their ability to balance and start, you know, aches and pains and that kind of thing. And I kind of looked at her and, suppressed my initial thoughts and was just like, well, why do you think that's going to happen? And she's like, well, it's just what happens. I was like, well, let's think about when you came here, how much balance did you have? Well, you know, it had gone away. Okay. And how long have you been here? At that point, they'd been there for, you know, a good amount of time. Did you see that balance come back? Did you see that as we worked on these things, did you see those qualities start to get better? She's like, yeah. Okay, now imagine if you were, because at this point, both these people were probably in their 60s, if you had started when you were my age, or you'd had the information available at my age, and had kept those qualities, trained to those qualities, tested those qualities, kept pushing the boundaries on those qualities, do you think that they would have regressed to the extent that they did by the time your age? Well, no. Okay, well, Evan and I have the ability, thankfully, that we know these things, and we're trying to help you guys do things, but we're doing those same things ourselves. All the little things that you guys think are boring and insignificant, we do all those things so that when we get to that age, we're not losing our balance. Now, there's going to be some natural regression, of course, but if I can stave that off and keep the percentage of regression down, why wouldn't I do everything in my power to do that? So yeah, I'm going to do stupid balance things and try to push my limits on that kind of stuff because I want to continually challenge my mind, challenge my body, because you know what, getting old it's a kind of a requirement, but how we go into that is completely on us.
I want to add to the rant because it's fun, but I'm gonna ask Brandon a question. What do you do whenever I get this all the time, but my input from my perspective or my experience may not be as valid? What do you do whenever someone comes and says, "Well, my doctor said I can't rotate"? How do you deal with those situations?
That was awesome.
It's tough for me personally, just because
I remember that conversation that client had with you.
I hear it all the time, and I want to laugh, but I know that my opinion will not be taken seriously.
So can I ask like what the person was to like rotate how, like their spine or like their shoulder or hip, knee?
That's such a good question.
You know, like
so. Specifically, I would say most of the time it's with some kind of low back issue.
Okay, so this is the like thing that I go into all the time because we'll get like lumbar fusions that I work with, and they have this. They're like, "Oh, it's fused down there," and I'm like, "Okay, well, like that's fine." The way that our spine moves is you have like 30 vertebrae or so, 20, whatever. I don't know the number. You can count them. 8, 12, and 5.
It's all right. We can
number. You have 20 some.
That's
You have 20 some vertebrae. So when you bend and when you rotate, it does not move as a single unit, right? So it's the total arc of movement is a summation of every single level moving together. So when you have one segment that's fused, you might have a limitation in a certain direction. So with like lumbar fusions, usually like extension is limited and like these rotation movements are limited. They're not completely gone. But what happens is I'll actually do this with them. I'll like, okay, stack your fists on top of mine. I'm like, okay, so if my fist moves here, the two on top of mine just moved too, and they haven't even moved yet, right? So it's that summation of movement that leads to the total arc of movement. And I kind of have that conversation with them. Sometimes people are receptive to it. Other times people are like, oh no, it's fused. That's like, they just don't believe me.
My entire spine is locked in place.
Well, I try not to create an argument, but I'm kind of like, how do you use the bathroom? How do you walk?
Yeah.
The gate cycle.
I try to like
a robot
show them or like have them do a movement, like a lower level movement or something that like trunk rotations where they're laying on their back and they just like, because to them it's like, oh, my knees are moving side to side.
Just being comfortable with the rotation.
Yeah. So like they're thinking like, oh, my knees are moving side to side. I'm like, how's that feel? They're like, oh, it feels all right. I'm like, okay, well, your back is what's moving right now. Like, this is what's happening.
Amazing.
And they're like, okay. I'm like, do you feel that stretch down there a little bit? And they're like, yeah. So they're kind of receptive with it. It really depends on the person too. Yeah. As bad as it sounds, like if somebody wants to get better, like they truly want to get better, they're going to be more receptive to what you have to say.
Yeah.
So. For sure. Because some people come in and they just go, the doctor said this, and they throw their hands in the air and this is what it is. And they're willing to accept that fate.
I've had patients come in. So with insurance now, you can't get an MRI for most like musculoskeletal pain unless you've gone to therapy first. You can't get a steroid injection unless you've gone to therapy first. So I'll have patients who come in, they're like, yeah, I'm just here for my 6 visits so we can get an MRI and figure out what's going on.
I'm sure
with
that's
me.
a great 6 visits.
Yeah. Their outcomes are terrible. One, they have a negative outlook on therapy.
Because they don't care. They don't think
they're
it's
like,
going to matter.
how's this? We haven't even seen what my back looks like yet, you know? And it's frustrating. That's I actually had I did a phone consultation with a guy on Thursday evening. He's having like headaches when he deadlifts. And I was like, okay, when's the last time you had a physical? So like, I'm doing some like screening here. And I'm like, when's the last time you had a physical? He's like, oh, probably like 4 years ago. I was like, do you know what your blood pressure is? And he said no.
Initially.
He said no. And I was like, okay, well, it would be beneficial for you to go and get a physical first, and like let's see what your blood pressure is, because it could be that, you know, that's a serious issue that we'd want to get addressed. And if it's not that, the other thing I can think of is it's probably related to like your posturing while you're deadlifting, you know. And I talked about like your suboccipitals and some of the upper cervical segments and things like that.
And then
I
you
was
lost him.
I was like, well, no, not that. I was like, we'll probably do some like a manipulation, like getting your neck popped, and we'll do some dry needling, that kind of stuff to help, like, you know, basically like free up some stiffness, because he was saying he had a lot of like stiffness in his neck. And then I was like, and we'll probably assess your deadlifting for him, you know. Told him all these things. So he ended up going to the doctor the next day, and he sends me a text, and he was like, yeah, I don't remember what the numbers were, but my doctor told me that my blood pressure was fine, and there was no way that your blood pressure could get that high during exercise to cause those symptoms. And I'm going to a chiropractor on the 26th, and they're going to do a more, I feel better about going to that because they're going to do a more thorough evaluation, and they're going to take an x-ray. So it's like everybody has this like thought or understanding that they need to have an image to see what is going on, and it's because of how routinely imaging is done,
Right.
and they don't know that it's actually impeding their ability to get better. So it's like, it's very frustrating for me.
I'm sure that doctor has also never done a max effort training at all whatsoever. Do you not know how, you know, how
Dude, look
high
at
your
Eddie
heart
Hall.
rate and your
Look at Eddie Hall.
Right.
Yeah.
Dude,
How
little
did
blood
die?
vessel in his right.
Yeah. I
Like-
mean, you know, temporarily your
You pull
blood pressure is going to
1,000
go up, you know,
pounds.
while you're training and doing that stuff. But there's no way that can be a cause.
That's like, yeah. And like the personal trainer that sent him to me for the or gave me his number for the
Yeah.
consultation.
Is the guy overweight?
Yeah, that's what I was going to say.
Yeah.
So like, again, going back to poor baseline level of health, very reactive in our healthcare.
Yeah.
You know, likelihood of him being hypertensive was higher, even though he went to the doctor and they said it was fine.
Yeah.
So
If it ain't broke, don't fix it.
people who have like a lower fitness level, they tend to have higher spikes in blood pressure and things like that in their vitals
'Cause it's
when
more
they're new to
stressful?
exercise. Yeah, they're not as cardiovascularly fit, so they get a larger response to exercise, and that response dampens with time. So it's a good thing. But in the initial stages of exercise, like, have you ever like not worked out for a while and then maybe did a HIIT workout and you get that metal taste in your mouth? You know what I'm talking about?
I haven't.
Yeah.
I know what you're talking
super
about, but I
fun.
haven't.
Okay,
Yeah.
that's because of you get that larger response to like a larger sympathetic response.
See,
Basically,
Evan is perfect, and he
I
never
am-
misses a workout.
I am-
Never eats outside of his game plan.
Yeah.
Like, yep, Evan is the perfect human specimen.
I am not.
His wife would 100% disagree.
She would. I have a question because I have an idea, but I'm not sure. But it happens to deal with blood pressure, and if someone is supine and doing some kind of dead bug exercise, you know, you could say, oh, you know, we're learning coordination with the core, and maybe like kind of teaching somebody how to brace and stuff.
Supine means flat on your back.
Yeah. So what if what
Just
if
trying to be
I
helpful.
know.
You know, I mean,
what if
Somebody's gotta
someone
be the lay
is,
person.
is feeling what I would think of as a blood pressure issue, and they say, oh, you know, I'm having a little bit of ringing in my ears with an exercise like that. What would be your approach with kind
Have
of
you-
assessing the situation?
have you had an experience like that?
Not
Like,
me personally, but with
I mean,
the
a
client.
patient
With
or
a client.
Yeah.
Yeah.
All
And
everybody
then
patients.
that, and then are you familiar with the reverse hyper machine?
Yeah.
Okay, same thing. So I wonder if it's pressure in the abdominal
I
or
was going to
something
ask
with
if they were
bracing
like
and
valves
holding
out,
their.
like
Yeah, I
they're going valsalvic. They're not actually bracing.
Yeah.
And the ringing is powerful enough that they cannot hear cues and they can't hear me speak at all whatsoever.
It's like a
Dang.
stress response, and it
That's-
gives you like auditory
that's pretty
occlusion.
significant.
That's what I think.
Yeah.
I think it's significant enough to get it checked out.
Yeah, I mean,
I'm
do you guys take blood pressure, or do you know how to take blood pressure?
I haven't done that in
No,
over
I think
a
it's-
decade.
Well, I think it's something that's pretty easy to learn.
Yeah.
And I think that like there's no issue with you guys, you know, doing that. I don't know if you have a screening process before like somebody signs up to, you know,
Yeah.
work with you guys, but it's a good thing to do. It's like the silent killer in America. 'Cause
Yeah.
Right, for sure. Well, it helps you just know what it is, and
Yeah.
it can be something too that you use as yet another trackable piece of information that
Yeah.
You can
And it takes like 5 minutes to do. If
right,
that,
in a quarter, you come
it's-
back and look at it again, take it again in a month or two, and go like, look, your baseline's higher or lower.
think it would be more associated with blood pressure versus something like in the neck or something like that. Would you tend to agree? Or say it's a good spot to look at first?
Sometimes when somebody has like an upper cervical dysfunction, they can get that tinnitus or tinnitus, whatever you want to call it.
Tinnitus.
But
Wherever you put the
I say tinnitus, but I've heard people say tinnitus, so I say both.
It's like aluminum or aluminium.
Yeah.
But it could be blood pressure. You know, that's always like safe to screen out or rule out first. So if you ever have a concern for blood pressure, always get that ruled out.
Yeah, that's the thing is I know that it happens, but it also bothers me a little bit.
Yeah, like if you can teach her or have her like try a dead bug,
It's a male.
or him,
Either one.
if you have them do the dead bug and do you guys have like a physio ball in the gym? So instead of like starting them with both legs up and arms up, like have them
Elevate the torso.
just hook lying, so like feet elevated on a box, and then put the physio ball between their knees and arms.
I got you.
So then they basically do this motion into the ball and make them breathe while they're holding. So that kind of teaches them to differentiate between breathing and bracing.
Right.
But if she can
That's
do that,
a very tough
it's like the
thing
bandit
to teach.
doing it like a reverse banded pullover style.
Yeah.
Where you're doing a dead bug.
I'll have people lay in hook lying and then basically like push in really hard and then cough. So they feel those muscles jump. And I'm like, okay, those muscles that you just, felt pop up, that's what we want to be able to feel. So whenever we do these exercises, I want you to be able to breathe at the same time. So you shouldn't be going purple, because you're holding your breath and bracing. Yeah. And I make people do 10-second holds, because typically a 10-second hold, if they're holding their breath, if they're holding their breath, they're going to be like,
right.
Yeah.
So
you'll find that they're not doing it correctly if you've got that 10-second hold.
They lose any tension that they could have had. They lose it all.
Yeah.
I would try the physio ball, and if that takes the ringing away, that can tell you so it could be a blood pressure issue paired with the poor bracing, right?
I've tested double leg reverse hyper versus just single leg reverse hyper, and I do think that it has something to do with bracing and blood pressure, because if there's less pressure, it doesn't exist. So
I didn't even just to go back to the tinnitus thing. I didn't realize that was something that was associated with like a cervical spine issue. So I don't know if you remember this or not, but our senior year of high school, I dislocated the vertebrae in my neck. So really bad idea. I was 195-pound nose tackle playing against like 300-pound centers. Not a great call. But I was like quick and kind of dumb. And so like I would just...
He was called the app.
Yeah.
Is the all-purpose pond.
Yes, all-purpose pond. At some point...
I almost like PAWN.
No, yeah. Yeah. So... Pretty much. Yeah. All right, that too.
Let's try it out.
100%. During a game... During the time playing football in high school, I played every position except for quarterback and kicker at some point, way, shape, or form. Because I just liked playing, and so and I knew the base enough to just throw him in there, he'll be fine. And so played nose to guard our senior year, and it was like a third and short kind of deal. And the center was 300-pounders. I think both guards were 280, something dumb. And so I grab the guard, and I take him and myself into the knees of the center. And my helmet gets stuck, and I roll up, and Bo Shields probably came over the top and did some superhero play and saved the day.
I was probably off the team by this point. I don't know.
You yes, yeah. So Brandon left the team, and we all almost left in protest. But anyhow, it was a great and dramatic.
I'm glad I know it's funny that you shared that story, but would you agree that you were probably at an appropriate body weight? Even though you don't think that you were big enough, but you're at an appropriate body weight and strong enough to play football to decrease the injury rate, but you also got messed up. So how the reason I bring that up is some sports are honestly just dangerous.
Oh, 100%.
And things are going to happen.
Right. Accidents happen, that kind of thing. And there are some times where it is what it is. I think that I was not, I was trying to gain weight. I just wasn't able to. I was, You know, and Garrett, looking back and now coaching high schoolers before, like, wasn't eating enough, wasn't sleeping enough. None of that stuff was right.
Yeah.
And all of that would have helped because,
Yeah.
I mean, legitimately speaking, that thing happened. I got up off the ground, couldn't use my left arm. And the team doctor goes, "Oh, it's a stinger. You're good." By the end of the game, like, I had a little more mobility and do that, play for a couple more weeks, end up going to my normal sports med doc. And he, like, looks at my x-ray and goes, "Oh, yeah, your C6 is out of place a little bit." And I'm like, "Oh, that's not good." End up doing nerve studies and all this stuff, finding all kinds of wonderfulness that went on. But long story short to all of that is I will occasionally have a little bit of ringing in my ears on occasion. And I've always been curious as to, like, man, is this from, like, you know, going to the range without my ear pro on? Is this because I was an idiot in high school and listened to music too loud? Like, but that having that connection point put together, it makes sense. Because it's never anything that's, like, long lasting, but it'll just kind of come and go. And I would imagine, and correct me if I'm wrong, either doing some kind of intervention, whether on the chiropractic end of things or doing more like building up of that musculature help. Was that anything, like, I don't know how that would work moving forward.
Here's my
about
take
needling
for the
or-
neck. Yeah, so needling. So it's called somatosensory tinnitus. Needling.
Diagnosing Jared on the podcast.
I was going to ask, like, if you notice it, if you've had, like, a higher stress day, if it comes on more often. It's not like, oh, you're faking it. It's just this is
right.
It's a thing.
Yeah, it definitely. I haven't paid a ton of attention to when it happens, but yeah, I mean that would make sense.
Yeah. So the upper cervical segments are. Let me go back to, like, the strengthening of the neck first. So there aren't really, like, big neck muscles, right? So like from a strength training wise, what are you doing? Like,
right.
Like there's the big one is, like, there's a thing called the deep neck flexor endurance test. So you basically lay on your back and then do a chin tuck and then hold your head up slightly. And if you can hold it for 30 seconds, that's supposed to be a good indicator of, like, reduced neck pain. But it's like, I don't put a whole lot of value in that.
Yeah.
So me being, like, a manual therapist, I do a crap ton of manual therapy for the neck. So with the needling, there are some, like, neural mechanisms that come into play. So when you have these somatosensory disorders, or like people can have migraines with halos, or they see, like, rings of light and things like that. That's a somatosensory disorder. But when you do the needling, it basically
It's tough to answer.
Yeah, there's, like, ascending and descending
moving parts.
pathways that are affected by dry needling, and that's where you can or cause some, like, change in symptoms, basically.
Gotcha.
With these like, issues. A lot of times it's the suboccipitals. Those are the needles that will dry needle. They sit at the base of the skull on the backside. They make a little triangle. I actually made a video on Wednesday, but Instagram wasn't working and it wouldn't post. Literally tried all day, and it just kept saying tap to retry. I was getting mad.
That's the
But
worst.
and I was talking about cervicogenic headaches, but it there's similar issues. But those muscles will get really tight or get in a spasm, and they can cause that somatosensory tinnitus. And it just has to do with whenever they do tighten up, they cause increased force across the upper cervical segments, and then that can produce these symptoms. Have you ever had a headache that started kind of at the base of the head and goes up and over behind the eye?
I actually don't get headaches ever since sophomore year of football.
Told you he's a perfect human.
That's it's
don't
not
get
being perfect. I
headaches.
think it's because I'm not perfect.
I'm Evan, and I don't get
isn't that
headaches.
odd? Never get a headache ever, unless I'm hungover.
Yeah, it's
I have a question.
I've been punched in the face too many
so-
times. I get headaches all the time and forget things. It happens.
I have a question selfishly about the neck specifically. When you do manual therapy on the neck, is it more of like a safe range of motion or isometric primarily? I know it's like a sensitive area, but training the neck, especially for really anybody, but a lot of athletes, it's grown over the years. So I just wondered what your take is on it.
I remember when we were in high school, they would have us get in like all fours, and then we would have somebody pushing down on the back of our head, pushing on the side. And we're trying to hold it in place and stuff. And it's just like, why? Like, there's not like, the most I'll do for the neck is if they're experiencing neck pain when they are like doing a certain lifting activity or something like that, I go straight to looking at form. Because most often than not, what are we told when we're in high school, when we're squatting, when we're deadlifting, to get the bar up,
Head up.
head up,
Yeah.
head up. So everybody,
Like excessively.
everybody is like craning their neck.
You ever seen those people that like go like they deadlift like
I
spot
don't-
and
I
they
don't
grab
wanna
under the
imagine
chin
that.
and they pull their deadlift athlete up? You ever seen that?
I
Oh my
have.
goodness, there's videos all over the internet of that. Like guys will like literally
It is
pulling a
exactly
heavy
what you're
weight,
imagining. Someone almost
standing
like
in front of them, like
spotting.
fingers splayed together, cupping their chin, pulling them up. And usually their athlete looks like a cat or like a dog taking a dump. Like their back is super rounded, the bar is pulled way down, and they're grabbing their athlete under the chin and pulling them up. And I'm like, what are you doing?
So like a lot of neck pain is just mechanical neck pain, meaning like there's either, so we have arthrokinematics. It's just how our joints move. There's a certain pattern that your joints are supposed to roll and glide whenever you turn your head, look side to side, tilt your head side to side, things like that. Usually that's when I do a manipulation. We're not putting things back into place. That's something you'll hear from like a chiropractor, and they'll tell you that I'm wrong, but I'll tell you that they're wrong. So we'll just go back and forth.
Yeah.
But the research shows that there's increased pressure on the joint. So it's basically like gas, like air bubbles. So when you get that pop, same thing in your knuckles, that's air. Okay. You didn't just put your knuckle back into place. Right? It's a cavitation, and that air comes back within like 30 minutes to 2 hours. You go to a manipulation course where they teach you all these manipulations. You sit down, you review a technique. They say why you do it. You do all these manipulations for about 20 minutes. You do a different one for 2 hours. Or you do a different one. Basically 2 hours have gone by and you go back to the one that you did at the beginning because the like physiological changes have taken place.
So like a retest kind of.
Yeah. Well, not a retest. You can do it again because the gas has built back up.
Okay, I got
So
you.
modalities and manual therapy alone, they're not good. They are good when you do them in conjunction with exercise. So like when I have people with neck pain, I do a lot of like shoulder strengthening, a lot of lower trap and middle trap strengthening. I don't know if do you guys do shrugs at all,
Personally,
or like have like people do them?
not very often.
Okay, good. So like upper trap is a muscle that is over dominant in everybody.
Yeah, not like a vertical, like trap raise. Usually, if they're on like some form of an incline bench, I'll do that, but I don't do it as much as I used to.
Yeah, I do a lot of like side lying exercises for lower and middle trap, just because like upper trap, since there's nothing opposing it, you'll see people who have this
Oh yeah.
thing. So it's not the fact that they have this like forward head posture. It's just that it's the muscles that are like in such a shortened position that it creates this like spasm feel and tightness, and that's what the pain is. There's some like research to show that posture has no correlation with neck pain, which blows your mind.
Really?
Yeah. It's like they looked at people who had forward head posture, and they looked at people who didn't. People with no forward head posture having neck pain, people who had forward head posture doing neck pain, they have them doing those cervical retractions, postural correction exercises, no change in symptoms. They go in and do dry needling manipulations, manual therapy techniques, and then just general strengthening of like the upper quarter, and they get better.
Yeah.
So it's like,
So you're not actually saying to tell some people listen out there like posture doesn't matter. That sounds so crazy.
posture does matter.
I know,
but
I get you.
For like,
because sometimes
People are very bad listeners.
Yeah. Well, posture doesn't matter. No problem.
no posture. I mean, I just said like if somebody's telling me that they have like pain when they're moving, the first thing I look at is how they're like posturing themselves when they're deadlifting.
I got
Or
you.
like when they're squatting. Posture matters.
Oh yeah.
But for like just neck pain in general, like if you're a desk worker and you sit like this all day, it's not the fact that you're sitting like this. It's just what the muscles are
It's
doing.
largely
basically.
the fact that you're not moving. Like there's a lot of that
Yes.
stuff that's like maybe you get more movement in, some of these things will go away. You know,
Last time I went through therapy, I learned a ton about the how important the mid and lower trap are and how to try and activate it. And I mean, most people, even if you're in the weight room trying to do everything perfect, you're still probably
You can't like turn off upper trap either.
Yeah.
It's like it's innervated by a nerve that is both a sensory and motor nerve. So there's no way to turn it off. But yeah, doing like lower and middle trap strengthening, your trap is this big diamond. If the middle and lower components aren't as strong, you're going to get this upward pull. So if you see people who are like, you know, they just look like they carry a lot of stress up here.
maybe they're just really muscular.
Well, it's like something we always talk about, and all our guys have as well, is this idea like if you look at somebody and they've got a good, like a well-developed back, like they're generally going to be good benchers, they're going to be stronger people, and they're going to have, generally speaking, have a lot less issues. Usually when we get people coming in, they're upper trap dominant, they're chest dominant, and like you said, they're rolled forward. Everything's pulled forward because they've never done a row of any kind in their life, and then you start working on some of these things and start strengthening that lower portion of your traps, start getting your lats engaged, and their ability to get to a more neutral-ish place ends up like being a whole lot easier.
The stronger the individual that I see, usually the less I see of this.
Yeah.
Would you agree?
The less dude, bro.
Sometimes
Depending.
I think it depends. Because you get like I had a bodybuilder that I work with, which he just got his pro card, and he got 8th in like I don't know what the what was it called?
Olympia?
Olympia, I think.
Like
And
the
it was in
Arnold?
Florida.
Real? Okay.
Yeah, it was in Florida this year. So it was originally he was supposed to go to Vegas for the like national show, and then because of COVID, it got moved to Phoenix. But he's in the masters class,
Nice.
but he got 8th nationwide in that. But he got his pro card, so that was cool.
That's impressive.
But anyways, dude is jacked.
Mm-hmm.
Weakest rotator cuff ever, and it's the specificity of training. If you never train the rotator
Is he
cuff,
just front out, pressing,
and
pressing?
super like large traps.
Yeah.
Like lower trap, middle trap look good, not strong. You know,
Yeah.
it's like
Hold on a second. Wait, hold on. Whoa. You mean to tell me that just because a muscle looks good, it's not super duper strong? I thought that's how it was.
Or functional,
Yeah.
probably.
one thing I will say, probably to make sure that like people just don't run off with the posture doesn't mean anything. So like when it comes to like evidence, so it's not just what the research says. So there's like, you know, personal experience, there is like empirical evidence, and then I can't remember what the third one is, but
Research is like is one part. It's one part of the picture. It
clinical
is-
experience.
there
That's
you
what
go.
it is. But
Yeah.
let me slap that. But yeah, it's always a combination of the three. Like you should not just take the research and say, oh, okay, that's it. That's the answer. Because
Mhm.
there are people who like for the shoulder. So if somebody's limited in external rotation, based off the arthrokinematics, we know that the humeral head translates anteriorly whenever you go into this position. So if you do a joint mob, so you pull somebody's arm out to the side where they're laying on their stomach, and you're basically pushing on the backside, pushing it forward, they don't respond well. If you do a posterior glide, so they're laying on their back, and you push them that way, they're going to get more external rotation. And it's the opposite of what the literature says. So it's like, that's the like where you don't always just take the research into
Right.
like as the gold
I
standard.
think that's the tough.
Right.
That is really challenging.
It's
like
really
conversations like this matter
Right.
because if you read research and you just follow the research, you're probably not going to get the best results.
It's really confusing for, and this is not in any way like trying to talk down towards anybody, but it's really challenging for the general population person that doesn't have experience and it doesn't have an education in this field to hear an article get released and the research shows this.
I think the best example of that right now is all of the like news coverage of COVID. Every time the CDC's recommendations change,
It's the new standard.
everybody's like, oh, they don't know what's going on.
Right.
You know, when's the last time they looked at the CDC website prior to this pandemic?
Oh yeah.
Right. They had no idea what the CDC
CDC
recommended prior to
updates their
this.
recommendations all the time as evidence changes. Like
Yep.
used to, they would say women shouldn't exercise because their uterus would fall out. Like,
Yeah, they couldn't.
Evidence
They
changes.
They couldn't run.
It's a real thing that some people thought.
Yeah, it's like evidence changes. It's a good thing that it changes because that means you're always getting like the most, evidence-based quality care. So,
And like you said, like you have to take all components, and that's why you go. I mean, the thing is like if I've got to a certain point, like I've got to take my car to a mechanic at a certain level of needing help. Like I have to go to somebody that knows more than me for certain help for certain things. And so like having a coach or a trainer or a PT that you trust helps kind of fill that in, because you can't only go and look and read every article on PubMed and then not have any background in either the clinical side of things or in the actual hands-on application of it, because sometimes there's percentage and ranges and outcome, differing outcomes. So every study has a statistical difference in what happened. And there are outliers, and you might be an outlier in a specific thing that coach can then apply their real world hands-on knowledge and actually take that research and that scientific information and apply it in an actual real way that actually makes a difference versus just reading numbers on a page.
Even then, how many times have you went to your mechanic and they don't know the answer because their technology doesn't tell them? Well, how about your experience? What does that tell you?
Yeah.
It's the same thing with research. You don't have all the answers. So what do you do?
Science
Just
is always behind.
Not making a decision?
right.
Right.
That is not an
and
answer.
the nature of science is it's a little behind usually. It just because like it takes time to do good studies. It takes time to see good outcomes. We talked about this with technology. How in 20 years, what will we see, the negative repercussions of having cell phones in our pockets all the time, or having cell phones next to us in bed all the time? Like,
There'll be a commercial.
who knows?
Have you or a loved one carried a cell phone for the last 20 years? Yes.
You may be part
You
of
may be
the
entitled to compensation or entitled to compensation.
Oh goodness. Yeah. Who knows? And that's the beauty of it is that like it's not the human body is incredibly complex, and we are still learning things about it. And there are so many things that go into it that it's a little bit of an art and a little bit of a science, and you kind of blend the two together for each individual you work with. That's why it's fun for me, at least. Like you never reach the end state. There's no end goal of I know everything that there is to know. I am perfect. I know I am God's gift to strength and conditioning or PT or the human body. Like there's not an end in learning.
The older I get and the more experienced I get, the more I tell people I don't know.
Yeah.
I usually have pretty good guesses, and my guesses now are better than prior years, but I'll still say I don't know because I'm pretty confident that I don't know, but I'll do this and this and this to see, but I'm not sure.
I have a lady who she has torn her rotator cuff all four. She needs a reverse total shoulder replacement, but she doesn't want to have surgery.
How did this happen? Just injury after injury after neglect.
Years of she's had her shoulder pain for years, but she needs a reverse total shoulder replacement. So they basically, instead of the humerus being the ball and the shoulder blade being the socket, they flip it around. So they make the shoulder blade the round surface, and then the prosthesis is now the cut or the socket, and then the deltoid becomes the primary mover of the shoulder. So that's the muscle that basically provides the stability to the shoulder now. And typically they have less range of motion, and then they have a 10-pound lifting restriction for the rest of their life with that arm. But she needs that, but she doesn't want to have it. And she's asking me
that or pain every day probably.
Yeah. Which you can strengthen the surrounding musculature. It's hit or miss on whether or not it works. So every day she's asking me you think this is going to get better? And I'm just I don't know.
Yeah. I'm guessing that would be the first approach, and strengthen the delts as much as you possibly can in the pec. And
some of it is, so you have to retrain how the shoulder moves. So you start them laying on their back. It's called a Jackins protocol, but you start them laying on their back, and she already has a hard time just raising her arm to straight up and down while she's on her back.
Is it from pain or weakness primarily?
Both.
Yeah,
Both.
okay.
Part of it is she gets the pain because there's no stability at the shoulder, because your rotator cuff takes your humeral head and rotates it backwards and down as you start to raise your arm up. So since she doesn't have a rotator cuff, basically she's getting impingement at the shoulder every time she raises her arm up, and that's what's painful. So
I think as soon as you said that, I think of like literally the circle of pain, and it's like pain, inactivity, atrophy,
yeah,
and it just never stops.
Yep.
And when do you put your foot down and try to go see somebody to get stronger?
And shoulder issues, like they're rough. Like they're not easy to I don't know, to live with if you stay away from them. So like something that I thought was weird, it's a good thing. It's just another case of how when you have some pain and your natural inclination is to avoid that movement, like you got to lean into it a little bit. And like, so like I've had 2 shoulder surgeries on this shoulder, collarbone's dislocated on this side. I got a little AC separation over here. It's super awesome. I did dumb things. And like, but I found that if I
you tackled a frozen snowman.
I did.
Tell me that.
I did not consume any alcohol. Whether you believe me or not is up to you. Bounce off that thing like a tree. Awesome. But yeah, so two labral tear surgeries on my left side. And then, like I said, that snowman incident did wonders for my right side of my shoulder. So both shoulders have had lots of issues. And like for the longest time, I hate overhead press. It's because A, I was bad at it, and B, like it hurt. And so like I made a dedicated effort to get better at it. So I started doing other things just to kind of strengthen up the supporting structures, and got to a place where like I was overhead pressing on the weekly in some way, shape, or form. And I noticed that like, so my schedule got changed and I got away from some things. And so my overhead pressing scaled way back. Within a couple of weeks, I could tell the shoulder issues that I had been having started to sneak back in. And it was just a good case in point of like, when you've got movements that hurt, like lean into them a little bit, start to get that movement back in there, because, movement is medicine. Like as much as it's cliche to say, like it really matters.
That's where the progressive tissue loading comes into play.
Definitely.
So that's why I love manual therapy, because somebody comes in with pain, you can modify or modulate their pain significantly and then load the tissue. It's the best way to do it, in my opinion.
100%.
Probably allows you to progress super fast.
Yeah. Yep.
You can skip so many steps.
Yeah, and that's a good, and like what you said earlier. Like if you only do the manual, like you miss out on the benefits of loading it. And if you only do the loading, then you miss out on a lot of the benefits of the manual therapy. And so you gotta put them together. It's been a recurring theme throughout this whole episode so far.
Mm-hmm.
I just kind of thought about this. If you do have an injury or like ache or pain, stop icing it. Don't ice it unless you have surgery.
We were talking about that last week.
Don't ice it.
That's crazy. The guy that came up with that protocol even released research later on saying that he was wrong. Like he released like a full up research article saying, "Hey, like I was wrong with the rice protocol. Like we should have taken ice out."
Part of me wonders, it's like, well, do you want to outsmart the body, or are you smarter than the body? Like too much inflammation, depending, like after surgeries and right after an injury, that can really hinder things.
Mm-hmm.
But stopping the process.
Yeah, that's why I say, like, if it's after surgery and you've had some kind of traumatic issue or traumatic tissue damage, which is what happens with surgery, you need to ice.
Mm-hmm.
Otherwise, you're going to be in a world of hurt.
Yeah.
If it's something that is like a musculoskeletal issue, so you were working out or you weren't working out and you just developed some like shoulder, back, hip, neck, ankle, whatever pain, knee pain, don't ice it.
Nope. And like this is super weird. Like I had somebody come in, they had like kind of sprained their ankle a little bit, and we were messing around with it. And again, when we talk about knowing things we shouldn't know, I guess, however you want to word that. Played around with a little bit of band distraction, played around a little bit of some body tempering stuff, and got movement back faster than normal. Got some positive outcomes, and that particular client like recovered faster and was able to get back onto doing things.
So like in Indiana, we have direct access now. So insurance. So like if you have TRICARE, you probably won't be able to use direct access just because TRICARE doesn't recognize direct access, which is dumb. Neither does Medicare. So if you're younger than 65 or you're not a veteran, this applies to you. So if you have like Blue Cross or some other like standard insurance or private insurance, In Indiana, we have direct access now, so you can go see a physical therapist without a script from your physician or your family doctor, and you can see them for up to 42 days. So for things like ankle sprains, or you have back pain or neck pain or shoulder pain that you just develop, you don't have to go see your doctor first. You can just call a PT clinic and say, hey, I want to get scheduled for an appointment. If you're paying cash for services, then you're not going to use your insurance. This applies to you. So if you wanted to work with somebody and you were just like, yeah, I'm just going to pay you instead of using my insurance, you can go see them. So,
and that's a really good option because it doesn't.
And if you're thinking, well, if I rolled my ankle, like, don't I need to be in a boot or something like that? Or like, what if I like fractured my ankle? So there are like assessments that we do to rule out fractures. One, you don't need to be in a boot. It's going to slow down your recovery process. So
You need blood flow to help her with recovery.
yeah, movement is good for those things. So
That's a lot of the clients that I see with big issues or recurring issues and injuries is how do we try to, you're not necessarily going to speed up the recovery process, but you can definitely slow it down by the things that you're doing or not doing. And whenever people like limit themselves or the doctor puts them in a position where it limits them, like, you're putting my hands behind my back.
Yeah.
It's really tough.
This goes back to that post that I had for like the heavy deadlifting and heavy squatting don't cause back pain. I like finished it off with, if your doctor tells you to stop lifting, you need a new doctor, because like there's no exercise that isn't like you can't modify it. There's not an exercise like that. You can always change up an exercise so that it's more appropriate and fits the person's needs at that time.
Yeah.
So like 100%. They need to move. Like a lot of doctors, like if you go with an injury, their first instinct is to immobilize you, because one, it's going to help reduce the pain, and that's the only thing that they're thinking about for the most part. So
if you can find, some variation of a squat or a deadlift or a super heavy carry, you're loading almost every single tissue in the body. You need to find a way to do it.
Yeah.
And if you can do it, you're probably going to be a little bit stronger. Your skeleton's going to be a little bit more dense. You're going to avoid all kinds of crazy stuff as you age, or at least push
100%.
it further away.
Right.
So not loading is,
progressive tissue loading is the name of the game. So, and
100%.
that's that like disconnect between like PTs and strength and conditioning. And I think it's where PT needs to improve.
Yeah.
It's not like you guys don't know it. It's PTs don't know it. Like I remember sitting in class. In
Maybe
PT
do you
school.
think it's like some PTs may think it's not their job to?
I just I think for them to be able to say that, they need to have that knowledge first to be able to be like, oh, it's not my job. Like they need to do that.
Because that's kind of what I think.
I think with like what our profession is supposed to be, we're supposed to be the people that help you get back to moving the way that you were before you started having pain. Like progressive tissue loading is a big part of that. It's like it is what we do acutely. Like somebody has a rotator cuff repair, first 6 weeks they're not doing anything. We're just moving their arm for them. Weeks 6 to 8, they're allowed to move their arm with some assistance. No lifting yet. Week 8, you can start adding weight, and that's where like the progressive tissue loading comes into play. But it's not anything that's like that. It's not periodization. It's not like you're doing percentages of 10 rep maxes or like things like that. Right. It's, hey, is this too heavy yet? Or hey, is this too much, or is it not enough? That's like the progressive tissue loading that most PTs do.
Gotcha.
The simplistic way I like to think about it is, if you're a swimmer and you get injured and you go to PT, they're going to get you back in the water and teach you how to swim. But then you probably need a coach if you want to swim to the level that you really want or that you really need to.
Yeah, and I think that's a good like.
I like analogies.
Example. Yeah.
Get you back. Well, like the PT gets you back on the track, and basically then strength and conditioning, or how you train for the rest of your life, is the rest of that marathon that you're running that is your life, and trying to get back into something that is sustainable, because you can't do PT forever.
My goal, so like I have like the dual background, so my goal is to eventually have a facility where if somebody has an injury or like just pain, they can come to me. I can acutely manage their pain and then work with them for the full process.
Right.
You know, like I get to do their strength and conditioning because they're at my place. I have a gym. I'm also rehabbing at the gym type of thing.
Right.
So
That's awesome.
Perfect.
That's awesome. That's the goal.
That's what like I want this to be. So
The end goal. Yeah. That's awesome. Well, it's been we're closing in on 2 hours. I don't know if you guys
Really?
It's been a bit.
Yeah.
Jeez.
Yeah, it goes fast.
It flew by.
That's the thing that always makes me laugh when people talk about like I can't listen to a 3-hour podcast. Oh, this stuff flies by if you know what you're talking. If you enjoy what you're engaged in it, man, you can talk forever.
The one I made was only 20 minutes and it took me like 4 hours.
Yeah. So yeah, we're closing in
Lord.
on 2 hours. I mean, I'm good with wrapping up this one. I think we've covered our main points, and
Solid for the first one.
yeah, I mean, maybe might be something we do on a more regular basis. I'm down. Any closing thoughts? Where can people find you? Social media? What are your tags,
on
handles, all that?
Social media, Instagram, it is Performance PT Indiana, and then it's the same for Facebook, and then on Twitter, it is PTIN Performance, and then I have a website as well. It's performanceptindiana.com.
Awesome.
So, yep.
And then obviously our guys, like I said, continue to send us questions, comments, concerns. If you guys send us some feedback, like, subscribe, rate, give us all your thoughts and feedback.
If you like more of these,
if you guys
types
like
of
these interviews,
conversations.
for sure, let us know if there's areas that Evan, Aaron, and I don't specialize in. If there's things that you guys want us to dig more into, let us know. Send an email to partycast@gmail.com, PRTYCAST@gmail.com. We're always open for suggestions. Should Evan get a haircut? Because I think he's starting to get in that homeless surfer look, should Jared talk less? Probably. So I think that's a wrap. Woo! Thank you for tuning in to this episode of PartyCast. Check us out on your favorite podcasting site. And remember, each episode is also available on YouTube. Thank you for joining us on this adventure, and we will see you next time.